Let's talk about transmission of respiratory infectious diseases. Respiratory infections are transmitted between two people when one is infectious and the other susceptible to infection.
When the infected person talks or coughs, they release a mist of particles made out of respiratory fluid that contains the virus. They can throw between 900 and 300,000 liquid particles from their mouth. These particles are less than 1 micron up to hundreds of microns in size. By comparison, the thickness of a human hair is about 100 microns.
One way to get infected is by contact transmission. When you touch a surface that has been contaminated by a virus and then touch your eyes or nose, you can get infected. There is not much evidence at all that this is the way you can get COVID-19.
The second way is when a spray of large particles, like a drop of rain, fly out of the infected person's mouth and land on your eyes, nose, or mouth. To get infected by this route, you must be close up to a person.
The third way you can get infected is by inhaling virus-containing particles that are floating in the air. This transmission route is called airborne or aerosol transmission. Some people think of an aerosol spray can of deodorant when they hear the word aerosol, but really an aerosol is just a bunch of particles suspended in the air.
Getting infected this way could happen by either being close up to a person, called short-range aerosol transmission, or when you're far away from a person, called long-range aerosol transmission. Animal studies, air sampling, and super spreading show that SARS-CoV-2 is transmitted by breathing in aerosols.
SARS-CoV-2 is an overdispersed pathogen like SARS and measles. This means as few as 10% of people transmit 80% of the infections, and many people barely transmit. Most infections happen within households, where one or two other people may be infected within your own bubble. Also unique to SARS-CoV-2 is that many transmissions are pre-symptomatic or asymptomatic, so you literally have no idea who is infectious. People are most infectious right before they have symptoms of the disease.
To prevent infections, we must control both short-range and long-range airborne transmission. Short-range is when you happen to be in close contact. If you are as close as 8 inches, you can get infected by a spray of large particles landing on your face. Between 8 inches and 6 feet, you will inhale the virus.
Long-range aerosol transmission also happens. This is how super spreading occurs, when you have a series of unfortunate events that happen all at once. A highly infectious person is indoors for a long time, shedding lots of virus, and there are also many susceptible people in the same space. The airborne virus begins to spread through the indoor space and builds up to high levels because there is poor ventilation, minimal surface deposition, and no air cleaning.
Why is this important? Because the way to minimize the risk is with different strategies. You will never prevent short-range aerosol transmission by improving your ventilation. The only way to prevent it is by wearing a good-fitting mask, staying socially distanced from the person, and quarantining upon possible exposure. And definitely when you start to show symptoms. The closer you are to somebody, the more virus you will encounter, so try to stay at least 6 feet apart.
To minimize the risk of long-range aerosol transmission and super spreading, we must treat this with ventilation and air cleaning, and still wear masks to reduce the amount of virus that you breathe in or that you may release. Reduce the number of people indoors so that the chance that somebody is infected goes down.
You cannot ventilate your way out of short-range transmission scenario, but you must ventilate your way out of a long-range aerosol transmission situation. And always use multiple strategies in case if one fails.
All right, so let's keep going. I'd love to share a little bit more with you about my recommendations. I'm going to start this video with this presentation with what I think we should be doing, and then I'll fill the middle with why, and then remind you again my recommendations. For short-range airborne transmission, as the video explained, we need to provide surgical masks to all staff and students and mandate wearing at all times in buildings. I know around here that is not the case, and it needs to be. Implement strict social distancing policies. For example, no eating together in the lunchroom. You can eat together outside. Implement strict quarantine as well, especially when you're showing symptoms or have been exposed. But I do not think you need to quarantine the whole school from a couple of cases. In super spreading events where long-range airborne transmission is a possibility, you should aggressively increase your ventilation rate. Your goal should be 5 to 6 air changes per hour. Windows and doors can help you achieve that, but you can also supplement with additional air cleaning. And I do recommend providing air cleaners for 600 to 1,000 square foot rooms, especially with 8 to 10 foot ceilings, and then using UV light for upper room air disinfection in much larger spaces. I also suggest adding carbon dioxide monitors to your space, and I will explain why, because that helps understand how much ventilation you're providing to each classroom. I want to back up and try to figure out what we know to date about school transmissions. The data is pretty interesting. It's not super clear that schools are at all driving this pandemic. What we see is there's no evidence of difference in positivity rate between teachers and other key workers from a study in the UK in as recently as September and October, where we find that teachers and education support staff are comparable to other professions and other key workers in terms of their infection rate. There's no consistent pattern in the data to date. It's not that closing schools lends to a decrease in cases or that opening schools leads to a surge in cases. And this was written by a report in Insights for Education. And the studies are complicated because there's a lot of confounding factors that go into trying to tease out this data. Plus, we're not collecting enough data in very good quality to actually answer the questions we need to be answering. A recent literature review is very good at trying to explain all the studies to date. And in their assessment, they say that susceptibility for children age 10 is relatively low compared to adults, but that mitigation measures should be implemented when opening schools, particularly secondary and high schools. And another study does support that there is a lot of transmission among staff. In the England summer school session, most of the outbreaks were staff to staff and then staff to student. Also some student to staff and very few student to student. And the number of outbreaks was very low. I think right now what we're really trying to reduce the possibility of outbreaks in schools. This is not what needs to be happening. And I think we're seeing that in the England data that does not happen. I also really wanted to highlight that this is an overall, a really important point, that a study out of Yale said overall level of community transmission is a really important parameter. We all know they're going up at very high rates, and it's very worrisome. Both policy and social context affects people's risk and outcomes, and that we also see where you live, because you have high transmission or not, and your race and ethnicity really factor into whether you're going to be testing positive or be hospitalized. And this level of disparity needs to be addressed. There's a COVID-19 school response dashboard. If you're not participating in this, I think that you should. It's a self-report option. It's a great opportunity because there is really no other place that's collecting data from all around the schools in the US, as far as I can tell. This was data from yesterday, where we see that student confirmed infection rates are 0.09%, or 6 per 100,000 students. The staff rates are about double those of the student rates. And we are now seeing a significant increase in school reporting. I know I've asked my kids' schools to start reporting on this dashboard as well. Over 3 million students are represented on this dashboard to date. I want to touch briefly on super spreading. I think this is our great fear, that we end up spreading a bunch of virus to most people indoors. It's a pretty, like I said in the video, it's a series of unfortunate events where you have somebody showing up with high levels of viral shedding. And in this simulation modeling study, which was very well done, they show that very high levels of RNA virus shedding is also responsible for very high numbers of secondary infections, and that's the graph on the upper right. On the lower right shows us how we might be able to mitigate these super spreading events, which is that we could either, what we want to do is get the mean R naught of the epidemic down to below 1. So we could either shut down our economies at about 50%. We know America is not going to go for that. So instead, we could also then get it below 1 by curbing gatherings at below 20 people. And if we curb them at 10 people, which is what the state of Colorado has since mandated, then this is how we could get that mean R naught below 1. We analyzed a Skagit Valley coral rehearsal outbreak that happened in March, and we used the Wells-Riley equation to estimate the emission of infectious airborne dose. My colleague, Dr. Zhang, will talk about that next. And then we wanted to explain how we could change the conditions, use a layering approach to reduce the risk of getting sick in this event. This is our first real evidence of aerosol transmission, and my colleagues and I, all here on the author list, immediately got together and said, this is aerosol transmission. We have to figure out what happened. We interviewed the coral members and we interviewed the facility managers, and we put together this analysis. The real event resulted in 87% infections of 61 people at the rehearsal for 2.5 hours. If you then decide, I'm going to change one thing in this event to see its effect, no matter what you do, one thing will reduce your risk by 50%. You can adjust the ventilation, you can do some air cleaning, you can give everyone a mask, or you can even shorten the duration time. Again, you're going to only reduce your risk to 50%. So we need to do them all. And that is why we are promoting this layered approach, or you can move the event outdoors. I'm also involved in the musician and performer study, where we got together in June and said we need to save music at the behest of NFHS James Weaver and Clemson's band director Mark Speed. We collaborate with the University of Maryland and University of Colorado, team together, and have been working on this problem for 6 months. I'm only going to share one slide here, but we are releasing a new set of data and recommendations this week. Our data in the lab shows that an aerodynamic particle sizer can help us find where the plume is of aerosol in the instrument. And we are measuring the plume coming right outside of this bell, of this clarinet, the picture in the middle, and it is masked with our bell cover. So looking at the total number concentration from an oboe, we see that when we have the surgical mask bell cover, and when we're reading, we have very low aerosol measurements in the chamber, which is a very clean chamber. But then when we take the bell cover off, the emissions increase. And the oboe we're showing here because it does have the most aerosol being released that we measured to date. Our bell covers are quite effective at reducing the emissions at the bell, upwards of 95%. And we also have mask efficiencies in front of the mouth of about 80 to 90% for theater performers and singers. The graphs on the right show the average concentration measured in all of our experiments. And we see the singers, release about 1 particle per cc for the short time that we're measuring. It's just a few minutes. And then when we put the mask on, it's significantly reduced. And again, comparing to the clarinet, we see the clarinet and the singer are both about the same levels, but the oboe is about 4 times higher. And there's really no emissions from a flute. Based on our studies, we have these following recommendations for music programs, and all across the country, music programs have stayed open and marching bands have stayed rehearsing and practicing. And we have no case of reported outbreaks to date for any program that is using our mitigation methods, such as the picture on the left, which is the St. Olaf band practicing using our mitigation strategies, which is to use masks on everything, only play indoors for 30 minutes, allowing time for the room to clean, and make sure you're distancing with good ventilation. I'm just going to speak briefly about ventilation, filtration, air cleaning with regards to schools. I want to touch on one thing. What is the right ventilation rate in an infectious disease outbreak? Well, what we look at is the literature that shows, if we're using low ventilation rates, it could cause an infectious disease outbreak, as we've seen now with the pandemic of COVID-19. In a tuberculosis outbreak in a university in Southeast Asia, we saw that their ventilation was 1.7 liters per second per person, very low. And a tuberculosis outbreak started in November and carried through the buildings. The CO2 was very high in these buildings, 3,200 parts per million, and the ventilation being too low. Immediately, the university decided, okay, we're going to address this with ventilation because tuberculosis is airborne. And so they increased the ventilation to 24 liters per second per person, and the CO2 levels came way down to about 600 parts per million, and the outbreak stopped. So we know that we have to increase the ventilation rate, and 24 liters per second per person is quite high. Right now for schools, ASHRAE recommends 6.7 liters per second per person, although unfortunately many schools are not following or have not met this guideline. If we use this kind of ASHRAE guideline for classes and we apply it to a 1,000 square foot classroom with a 10-foot ceiling, what we can then understand is the design ventilation rate in this space, and that is 455 cubic feet per minute. That's supposed to be provided to this classroom. Now that corresponds to an air change rate of 3 air changes per hour. And that tells us that it would take 20 minutes for 60% of the room air to be exchanged with outside air. So I think for schools, a 3 air change per hour is a minimum target that you need to ensure, but that according to my recommendations and the World Health Organization, other literature, we suggest getting up to 6 at least or higher if you can. We also recommend, and it's been used for decades, it's not a new idea, we use CO2 as an analog for ventilation. In this diagram, we see an infector releasing viral aerosol, and also this is the viral aerosol in red and the CO2 in blue. They both are coming out of your respiratory system, and the CO2 is then exchanged with outdoor air. Now, the particles do a little bit more than that. They can be removed by air cleaning, by ventilation, by surface deposition, and by inactivation. So CO2 is a great proxy for ventilation. It does not tell you what's happening with particles. If you go and take your CO2 monitor outside with, and this is an AirNet monitor, you get 445 parts per million. It used to be 350, right? It's going up. In a car, and you close everything down and you start recirculating the air, you can get quickly up to almost 5,000 parts per million. If you then turn on your ventilation system to bring in outside air, it drops to about 800 parts per million. I recommend putting CO2 monitors in classrooms and maintaining the CO2 level between 600 and 800 parts per million. CO2 was used as a proxy in a great study by Mark Mendel in California, showing that classroom ventilation was associated with illness absence. If you increase the ventilation rate from the current mean of 4 to the California standard of 7 liters per second per person, which meets the ASHRAE guidelines, that would reduce your illness absence by 3 to 5%. And then increasing it even further to about 9 liters per second per person would reduce your illness absence up to 10%. And we can see the data here on the right that shows the mean ventilation rates for different areas of California. And the lower your ventilation rate, the lower and it's related to CO2. So if you have a high ventilation rate, you have a low CO2. And so this does give us some understanding of CO2, ventilation, and illness. This is a fantastic study which tried to understand how schools were involved in propagating infectious diseases. It was an extensive simulation done in assessing schools and their role in propagating an infection, an airborne infection like flu in Hong Kong. They simulated real schools and real contact networks. So that means as a parent, I could I could infect my kiddo, or my kiddo could go out with me to the restaurant, and then we could be exposed there. And assessing all the different places you could possibly get infected, including the schools. And then they looked at all the mitigation measures that we would use in a school. What we see is that there could be a 9% decrease in the baseline infection rate by using these three scenarios that could be implemented in schools. The first one is to actually focus strictly on ventilation rate, which is to increase school and home ventilation rates to 5 air changes per hour. Now, home ventilation rates are typically under 1 air change per hour, so we'd need to ensure everyone was improving their home ventilation rate. Then you could go to either increase school and home ventilation rate, or do 100% isolation of all cases of disease. And then you could also add, well, let's close the targeted schools at 5 cases. And we see that that does not give us incrementally much more safety in infection. Harvard has some really great information out on how to keep your school safe and what to do. The reason I point this out is that when you are opening your windows, you can increase your air change per hour. So the mechanical ventilation in this data showed us about 2 air changes per hour. You open the windows, you can get up to 4, and you open the doors and you can get up to 6. We have a little bit more on air cleaning, which is that we want to quantify the air cleaner performance using the clean air delivery rate. Please make sure every air cleaner you purchase and put in a room is sized appropriately for that room. And if it's sized appropriately, you can get much faster decay in any pollution in your room compared to no air cleaner. In this particular study, we were comparing different bioaerosols, and this holds true for virus as well. The clean air delivery rate of air cleaner 1 was 170 cubic feet per minute. That could clean a 30 cubic meter room. But a $700, very nice looking clean air delivery rate of 25 air cleaner 2 could only clean a 4 cubic meter space. And so there are products on the market that will not do anything for you. We've put together this Harvard CU portable air cleaner tool, and I really recommend, if you haven't used it, to do it so you can size your air cleaners effectively. You enter everything in yellow, put in the square footage and the ceiling height of your space. You put in the clean air delivery rate of the air cleaner you would like to purchase. You tell it, well, I think my school has low ventilation, but it might have good ventilation, and hopefully your facilities managers will help you with that. And then you can see what your total air change in the room will be with your added air cleaner plus your ventilation rate. And I think you want to really target to get up between 5 and 6 air changes per hour. For very big spaces, you also might consider upper room germicidal UV, where we irradiate the upper zone of the room and we keep the lower zone, the occupied zone, free of radiation. We are designing systems like this currently for homeless shelters, and we have used them in healthcare facilities and hospitals and other places. We have provided detailed guidance to the CDC on how to do upper room UV, and that is found here. But I want to point out that another study showed that UV was singly the most effective approach combined with isolation and vaccination against airborne infectious diseases. So again, conclusions. I'd like to leave you with 3 important ideas. One is that there's devastating consequences to kids being out of school. It's a national priority. It hasn't been. It's been poorly handled, and we need to do better. The return to school should be prioritized over other aspects of the economy. It should be the last to close and the first to reopen, specifically in this pandemic, where we do not see a lot of data showing that schools are driving the pandemic. We cannot do school as usual. We need to do a layered defense risk reduction strategy. We know that the infection and fatality rate for kids is very low. The overall risk lens has to include number 1 and number 3. Number 3 is designed to protect both kids and adults in the school. And leaving you again with my conclusions on how to prevent short-range transmission resulting in a few cases, and making sure you're not going to end up with a super spreading event. Thank you very much.